Today we are going to continue our Chief Resident podcast project with Dr. Juan Pablo Zhenlio, affectionately known to all of us here as JP. JP has had a long history with us here in Rhode Island. He did both his undergraduate and medical school studies at Brown University, and then joined us here at Brown Surgery for his residency training. JP is going to be going off next year to do some international work in surgery, and we wish him well in that endeavor. So I'd like to welcome Dr. Juan Pablo Zhenlio to the podcast today.
Hi, how are you?
So JP, you're touching on an important topic that we see quite often on the acute care service or trauma surgery, which are crush injury and compartment syndrome. They are really two different processes with somewhat similar pathophysiology, and I think we frequently discuss them synonymously. So my first question to you is, why is this the case, and can you distinguish between these two processes for us?
You're absolutely right in that we do see a lot of these diagnoses here at Rhode Island Hospital, and they're frequently confused from one another. They're often discussed together, and it's really important that we understand how the two are similar and also recognize the differences between the two, because recognizing these differences can have really significant outcomes.
So can you talk a little bit about the pathophysiology of both compartment syndrome and crush injury?
Absolutely. The way that I like to think about these two processes is that compartment syndrome is an internally driven process, while crush syndrome is more of an externally driven process. Let's start with compartment syndrome. This is usually secondary to a type of deep tissue injury associated with swelling within a confined space. The confined space is most often defined by a fascial layer of some kind. This results in elevated pressures within the space. Now, compartment syndrome can occur within any closed space. It can happen within the compartments of an extremity. It can happen in the abdomen. It can happen in the pericardial space or in the intracranial space as well. The main compartment syndrome that we see happens within the lower extremities, and that's what's most commonly confused with crush syndrome.
So in what types of situations or conditions do we typically see compartment syndrome?
Compartment syndrome can occur in both traumatic and non-traumatic situations. Non-traumatic examples being injections into the compartment, massive fluid resuscitation. There can be insect, snakes, or animal bites that can result in this. Spontaneous hematomas from anticoagulation, or DVTs can be associated as well.
I think that's a good overview, JP. But those aren't what we typically see here in the acute setting, right? We typically see more of the traumatic compartment syndrome.
The traumatic compartment syndrome injuries are most commonly associated with acute fractures. The elevated compartment pressures create a gradient that can restrict tissue perfusion. This results in local ischemia and necrosis. This begins a cascade and a cycle of ischemia-related cell death that furthers the deep tissue injury. Then, this further increases compartment pressures, which then further results in cell death, and this is an ongoing cycle until the pressures are relieved.
So how does this process differ from crush syndrome?
As I said earlier, crush syndrome is more of an externally driven process that results from prolonged pressure onto areas of muscle that results in necrosis.
And we're talking primarily about skeletal muscle here.
Correct. It can be concentrated pressure over one specific area of muscle, or a larger, more distributed area over a larger area of muscle. When a skeletal muscle membrane is disturbed, it releases all of its intracellular ions and proteins, such as potassium and myoglobin. When high levels of potassium is released systemically, it can lead to fatal cardiac arrhythmias, such as ventricular fibrillation. When high levels of myoglobin are released systemically, it can result in rhabdomyolysis. During a crush injury, the large myoglobin molecules travel to the kidney where they are unable to be filtered and can cause a tubule obstruction, resulting in kidney injury, kidney failure, and possibly needing dialysis. The necrosis and release of intracellular contents in a crush syndrome can certainly result in deep tissue injury that begins the cascade I mentioned earlier, leading to compartment syndrome. And here is why the two can be confused with each other.
So I think for the listeners, JP, I think it's important if we try to break these two diagnoses up separately. When should you suspect compartment syndrome?
I think that if I have a patient who has had a history of a traumatic injury to the lower extremities, a vascular injury, or a burn to the extremities, approximately 75% of lower extremity compartment syndromes is related to a long bone fracture. Commonly, the 5 Ps are taught to students as signs of compartment syndrome.
What are those?
Very commonly, the 5 Ps are taught to medical students as signs of compartment syndrome, and these include pain, pallor, poikilothermia, which is coolness to touch, paresthesias, and pulselessness.
In your experience, how often have you seen the 5Ps classically on physical exam?
It's very rare to see all 5Ps together. Pain out of proportion may be the earliest sign of a compartment syndrome, while the other Ps may not appear until very late, and by the time that they do appear, there may already be irreversible damage. Severe pain may be an early sign of compartment syndrome, however, the other Ps may not appear until late, and by the time that they do appear, there may already have been irreversible damage done. Some patients may also have other concomitant injuries, with some injuries that are immediately life-threatening and required to be addressed first. Even though these injuries are being addressed first, it's important to still keep in mind that they can develop a compartment syndrome later on in their hospital course. There may also be patients that come in that are obtunded or unable to provide any history of their own, and therefore having this high degree of suspicion is of the utmost importance. More specific exam findings of compartment syndrome can depend on the individual compartment that is involved and the structures within it. For example, within the lower leg, the anterior compartment is the most common one involved. Within here are extensor muscles of the foot, the anterior tibial artery, and a deep perineal nerve. When pressures become too high, one might find a loss of sensation between the first and second toes and weakness with dorsiflexion or foot drop. And this would vary depending on which compartment is involved.
How reliable is your physical exam when diagnosing compartment syndrome?
The physical exam may not be very reliable in diagnosing compartment syndrome, and this may be due to body habitus, subcutaneous tissues, subjective interpretations of whether something is full, tight, or soft. If there is suspicion of tense or tight compartments, then the diagnoses can be affirmed by measuring the compartment pressures using a manometer. The Stryker device is what we use here at Rhode Island Hospital.
Can you talk a little bit about the Stryker device and how you actually get a compartment pressure with it?
Yeah. The Stryker needle is primarily composed of three parts. There's the needle itself, there is the saline, and then there's a manometer that reads the pressure. We insert the needle through the skin perpendicularly, and we want to make sure that we feel it pop through the fascia into the compartment. At that point, we inject a small volume of saline into the compartment, and then the manometer can measure the resistance from tissue pressure. It's important to note, though, that these measurements can vary and depend on the technique of the operator.
I think that's an important point there also. And for those who don't have a Stryker device, you could also get these pressures similar to getting like a bladder pressure or any other compartmental pressure, as long as there's transducer set up for pressure assessment. As long as you have a column of fluid or saline hooked up to a needle, you can also do this with the same setup that you use for an arterial line pressure.
Patients may also not tolerate having a needle placed into their legs or other extremities. And so those other tools that you had mentioned can be helpful.
I think it's important to note here, too, because we see some discrepancies depending on the service that's obtaining these compartment pressures, is whether we use the absolute number or the delta pressure to get your compartment pressure and base your interventions on. Can you talk a little bit about that?
Absolutely. In order to interpret the measurements that we obtain, we can follow two different schools of thought. One is, as you mentioned, the absolute pressure, and the number that is typically used is 30 millimeters of mercury. If a measured pressure is over 30 millimeters of mercury, then the diagnosis of compartment syndrome may be affirmed. The other method of interpreting these numbers is that the measurement that you obtain is compared to the diastolic pressure of the patient. If the difference between the diastolic pressure and the measured compartment pressure is less than 30, then that may also affirm the diagnosis of compartment syndrome. Also important to keep in mind is that variability in hemodynamics can affect the significance of these numbers, and patients with systemic hypertension may require higher pressures before they develop compartment syndrome, and patients with peripheral vascular disease may still develop compartment syndrome with lower pressures. If your clinical suspicion is high for compartment syndrome with or without compartment pressure measurements, then you should proceed directly to surgical intervention.
I think that's a good point, too, because there's a lot of advocates for the use of the delta pressure, which I think is gaining more widespread favor because using just an absolute number can lead to some unneeded fasciotomies. So how do you manage these patients with compartment syndrome?
The goal of surgical intervention is to release the pressure within the compartment and to prevent ongoing ischemia, whether this be in the gluteal compartments, the upper extremities, or the lower extremities. Most commonly, when we perform fasciotomies on, let's say, the lower extremities, we would do a 4-compartment fasciotomy because you want to make sure that you get to every single compartment. In the case here, we have the anterior, the lateral, the deep posterior, and the superficial posterior compartments. A common mistake that is made is that the fasciotomies are not large enough, and you want to make sure that if you're going to the operating room, you perform an adequate fasciotomy.
I think that's important because literature does show that any delay in performing these fasciotomies does increase morbidity, including the need for amputation in these patients.
Why don't we switch gears a little bit right now and go over the crush injury pattern? When should you suspect that a patient has a crush injury?
Patients with crush injury require an even higher level of suspicion than with compartment syndrome. With regards to the patient's history, they may be unable to provide any because they were found down due to an overdose, a seizure, or a stroke, or syncopal or cardiac event. These patients may be unable to communicate anything to you at all in presentation.
I think that's important, especially because a lot of these patients who do present to the ED, a lot of them are unable to communicate with us in terms of how long they were down or what were the events leading up to their fall. Your mention of having a high index of suspicion for these diagnoses is of utmost importance here.
I'd also like to make a comment that in some institutions or in some emergency rooms, the surgical team may not even be involved in seeing these patients who are found because of a medical reason and are evaluated by a medical or emergency room doctor and admitted to the medical service, and it can be several hours before any surgical evaluation is performed.
Can we talk a little bit about the exam findings for crush injury?
These patients may have even more subtle exam findings than compartment syndrome. Patients with crush injury may actually present with a completely normal exam, and there could be no signs that there ever was a pressure injury. They may have at most areas of erythema or ecchymosis. With severe crush injury and associated rhabdomyolysis, the patient may have dark tea-colored urine, which should raise one's suspicion. And when the history is concerning for crush injury, you can check a creatinine kinase level and trend it. Creatinine kinase is a product of muscle breakdown, and increasing levels should indicate that there is ongoing muscle necrosis.
I think that's another point that sort of gets confusing when you measure it here because our lab values only measure up to a particular level. I think the cutoff before you have to start asking them to dilute it down is...
It's 20,000. Whenever we order it, as part of the comments of the order, we will always ask for them to dilute it. And I've seen numbers after dilution that have gone up over 200,000. And therefore, it's really important that we do get the absolute number.
I think it's important to note that there's no correlation between the absolute number and the degree of muscle necrosis here.
You're absolutely right, and it's really the trend that we pay attention to, that we want to make sure that number is not continuing to go up, which would indicate ongoing muscle necrosis. In addition to measuring the creatinine kinase level, we also need to make sure we monitor electrolytes such as potassium, monitor their heart rhythm to observe for any cardiac dysrhythmias, and also monitor their renal function.
Yeah, I think this is an important topic because we've experienced this a few times here where the patient comes in and needs urgent surgical intervention, but they have some electrolyte abnormalities that have to be addressed prior to them going to the operating room. Can you talk about these patients and what your operative strategy is to try to get them to the operating room as efficiently as possible, but yet deal with some of these electrolyte abnormalities that you see?
One of the most important things to do first is to stabilize the patient's cardiac dysrhythmia. Oftentimes, it's a hyperkalemic process that is driving this, giving calcium gluconate, giving insulin, driving that potassium down. We work very closely with our renal colleagues, and this is a combined effort to lower the patient's hyperkalemia. If medical management is not enough, then we would start emergent dialysis.
Yeah, I think that's important, JP, because there are instances where the patient has such significant hyperkalemia that you can't get them to the operating room in an efficient time, and it's really important upon us to work with our renal colleagues to get them to an ICU environment where they can get dialysis emergently and then get them to the operating room, because the last thing we want is one of these patients to have a poor outcome on the operating room table because we didn't address their electrolyte abnormalities prior to surgical intervention. So what would be your indications to take these patients with crush injury to the operating room?
I think that the patients who have a continuously rising creatinine kinase level, who are critically ill due to acute renal failure related to their rhabdomyolysis, or in some form of septic shock related to their muscle necrosis require urgent surgical intervention. The goal of surgical management of a crush syndrome is to first and foremost obtain source control of necrotic muscle tissue. Having a suspicion or location of where this muscle necrosis is will assist in planning of patient positioning and where to incise and debride the muscles. As mentioned before, our history and exam may provide us with very little information to start with. In addition to muscle debridement, sometimes with really severe necrosis, an amputation may be required.
Is there any utility for using compartment pressures in crush injury?
There is no utility, and the reason is that this is a process of muscle necrosis, and we want to be able to diagnose this as early as possible. Pressures may not be elevated until very severe muscle necrosis has already occurred.
Yeah, I think that's an important point, and this is really where your physical exam is going to take precedent, especially noting any skin changes over the area, which are an important marker of the site of necrosis. Can you just expand a little bit on resuscitation strategies for these patients, especially with crush injury because of the electrolyte abnormalities?
Absolutely. I think that oftentimes these patients are coming in already very volume deplete. They require an aggressive strategy of hydration. These patients may come in with a combination of a hypovolemic and septic shock due to their muscle necrosis, and so they require aggressive fluid hydration. Similarly to treating with septic shock, I think that starting them at a fluid rate of 30 milliliters per kilogram is a good start.
Yeah, I think it's important to know just resuscitating these patients to euvolemia to achieve adequate tissue perfusion, and obviously we want to avoid excess fluid administration in these patients to prevent some other issues down the line.
So I think just finishing up, JP, can you provide some key takeaways from this discussion for the audience on both compartment syndrome and crush injury in terms of both workup and management?
I hope that the listeners are able to take away from this that the two are not mutually exclusive, but they are two different processes that have different pathophysiologic mechanisms. Early suspicion and diagnosis can avoid significant morbidity in these patients. If compartment syndrome is suspected, then early fasciotomies is key. If crush syndrome is suspected, then early muscle debridement is key.
Well, thanks for this discussion, JP. I think it's going to be really helpful, especially for residents who are managing these diagnoses here with us. I appreciate your time and your insight into these diagnoses.
Really glad to be here.
So thanks again to Dr. Juan Pablo Zhenlio for joining me today to discuss the workup and management of both crush and compartment syndrome. I'm sure the residents will find this review helpful as they prepare for a rotation on the acute care or trauma surgery service. Next week, we will continue our Chief Podcast project with Dr. Haley Leasley on the management of esophageal perforations. Stay tuned for that and other upcoming discussions on carotid disease, how to prepare for resident teaching cases, and aortitis, to name a few. We will also be doing a special podcast takeover in a few weeks with some of our previous Brown Critical Care Fellows and faculty, so be on the lookout for that. Have a great week, and I'm looking forward to having you back with us in the next episode.